60-year-old woman came to my office with complaining of gradually decreasing vision. Visual acuity of her eye was a finger count. Fundus examination revealed bullous retinal detachment and macular hole. She had highly myopic eyes with axial length of about 30 millimeters. We decided to perform vitrectomy with making the flap of the interlimited membrane to cover the macular hole. The core and the posterior vitreous was removed cautiously, avoiding unintentional start of draining subretinal fluid through the macular hole. Heavy liquid or perfluoride octane was introduced on the disc. PFO should be injected gently not to make a break and subretinal heavy liquid. The peripheral detachment became more bullous without drainage of the subretinal fluid, so it was confirmed that there was no break other than the macular hole. The peripheral vitreous was removed as completely as possible. The bullous retina was helpful to remove the peripheral vitreous without scleral indentation. After cauterization of the retina with the intraocular diathermy, retinotomy was performed to drain the subretinal fluid. Retinotomy is required as subretinal fluid cannot be drained after covering the macular hole with the ILM flap. I use Thanos meniscus contact lens. It provides an excellent resolution and contrast. The interlimited membrane was stained using brilliant blue G. After identifying the location of the macular hole, I started to peel the ILM along the imaginary line for the ILM flap. First, the ILM was removed horizontally about 1 disc diameter apart from the superior margin of the macular hole. Next, the nasal and the temporal ILM was removed from inferior to superior. Peeling the ILM in macular hole retinal detachment is difficult. The retina of the highly myopic eye is thin, and the retina is detached and no counter force exists against the peeling force. The ILM was peeled piece by piece with no rush. Compared to the nasal macula, the one side is anchored to the optic disc. The temporal macula is more difficult to remove the ILM from. It is easier to peel the ILM from nasal to temporal direction. Finally, the ILM was removed to remain the designated area for the flap. The redundant flap can be trimmed using the vitreous cutter. The ILM of flap was peeled, leaving some attachment at the margin of the macular hole. It should be peeled cautiously not to make a tear in the flap. The flap was flipped and spread, covering the macular hole with closed forceps. Perfluoride octane was introduced gently again to keep the inverted ILM flap in the position. PFO was injected further, just below to the retinotomy site. The fluid was exchanged with air. Subretinal fluid was drained internally as completely as possible before removing PFO. After applying 1 or 2 rows of the barrier laser along the break, PFO was removed. Just after removing PFO, silicone oil was injected to prevent displacement of the flap. The method of silicone tamponade is that you may have a second chance for closing macular hole during surgery for silicone removal in case of flap failure or missing flap. In the next day of operation, the retina was reattached. The closure of the macular hole was confirmed in OCT. 2 months later, the silicone hole was removed and the macular hole was still closed. Visual acuity improved to 0.16 or 20/125. Thank you for watching.